Okay, so if I can just repeat that to the students, and if you've got questions as you go through, pop them in the chat box so that we can field them as Philippa and Emma and Ashley go through their session. Does that sound okay?
Lovely.
Okay,
Thank you.
Thank you.
Hi everybody. First of all, apologies. Obviously Alder Hey Firewall is really working very well because it won't let anybody in. I'm not very good on IT, I have to be honest. I'd rather do face-to-face. However, where we're at this moment, I'm quite happy to do it. So this is about the power of play at Alder Hey and how we work and process as a team. So we have a play service manager who is a band 6. And obviously she takes the role and the management of the team, ensuring that all areas in the hospital are covered. We have senior health play specialist, which is myself. So for me, for my qualifications, I've done my nursery nurse training, which is equivalent to MVQ level 3. And then I've done my health play specialist foundation course. And then I've done paediatric pain management at John Moores University. And that ensures that I'm a senior, which is a band 5. And just for interest, so you know, that is round about 29,000–30,000 a year for a band 5. The play service manager is a band 6. So I've worked in the trust for quite a long time, 31 years this year, and thoroughly enjoy my job as a health play specialist, but didn't actually start off there. I had to start off as a band 3 play leader and work my way up. So that's the reason for today's talk, to explain how your career development can get in and into the trust in particular, working as a play assistant, play leader, play specialist, senior health play specialist, and a play service manager also. So a health play specialist is a band 4, and they've obviously done the MVQ level 3 or nursery nurse equivalent, and then they've done the health play specialist course at either Bolton, now it's at Leeds, and the equivalent is apprenticeship as well for that one. And then we have play leaders, and they're a band 3. So they're MVQ level 3 trained or nursery nursing NNEB trained. And that play leader, they're paramount to us on the ward as play specialists. They'll come on and facilitate the play, which is really important. And as play specialists, we facilitate, supervise and structure play activities for children 0 to 18 years, with also by implementing preparation and distraction for procedures as well. So the roles that are there within that triangle, we do fit together as a puzzle, and that's important that we work together as a team, using the skills that each of us have and demonstrating good patient positive experience for our patients. So the first person I'm going to introduce you to is Ashley, who is one of our play leaders here in the trust, so she can tell you a little bit more about her role in depth.
Hi everyone, it's Ashley. I'm a play leader here at Alder Hey and I've worked here since July 2017. I work on the cardiac ward alongside one of our health play specialists, Lorna. So as well as keeping children on our ward busy with games, toys and the activities, we also help in other ways too. So we've got organising and cleaning of the playroom, so we follow the trust policies. We have to make sure that we're up to date with any changes in the cleaning policies, especially now in the times that we're in. We're facilitating and offering a choice of play activities for each patient, whether this be at the bedside or in the playroom. At the minute, it's usually at the bedside, just with the current COVID situation that we're in. The cleaning process only really allows 2 children to make use of the playroom, as it has to be cleaned before and after each patient, and we've also got to make time for the rest of the patients on the ward to provide play for them. So we can provide a range of board games, toys, crafts or painting, relaxation or developmental activities. Some children might want to do this with us, or they might just want their parents with them when they first meet us. The majority of the children are happy to engage with us straight away though. The play we provide can be for a number of different reasons, so whether it be developmental or therapeutic play, play to reduce anxiety, or just in play in general to take their minds off being in hospital and have a positive experience while they're here. It can help maintain a child's level of development during illness and help prevent progression. So some children who come into our care might regress developmentally, just depending on their condition and the types of procedures that take place. So we can usually help use play to help build the development of the child back up and aim to be where they were before they arrived with us at the hospital. And we also work alongside other multidisciplinary teams.
Can I just interrupt for a moment? Are you going through slides, because our slides aren't changing?
Are they not?
So I'm reading off this one slide at the minute.
We're still on the power of play at the moment.
Are you?
Yeah. Are you in the slideshow?
Yeah, I went into that.
No, we're still seeing your format, your sort of overall format, with the slides at the side.
Yeah. That's it there, isn't it?
What does
slideshow? Where? Slideshow, that's what I shared.
Just hover. No.
That's to stop sharing, isn't it?
So let me try. Go back to sharing it. It's gone on there.
It's that one. It was on. Can you see that now?
It's at the moment we can just see you, but sometimes there's a little bit of a delay. Click share.
Onto that one.
Yeah.
No. Are you happy for us just to talk through it? I'm really sorry that you can't see the slides.
That's fine. Well, perhaps if you put the outline back up again, if that's okay, because then we could see the small slides at the side. We just couldn't see anything changing. So the big slide that we could see was the first one.
Can you see that one? Role of the play leader.
No, we can't. We can only see you at the moment.
I'm so sorry. I'm like an old woman. I really apologise to everybody on my behalf for that one.
One of my colleagues just said, click show PowerPoint first and then share screen.
Right. Share content. It's just not letting me share it, is it?
Sometimes it does freeze on the first slide. That's another of my colleagues has said that. Yeah.
I've put the slideshow back up again now. Can you see that first slide or not?
No, we can just see you still. So Emma's saying share content and then desktop.
We tried that.
Yeah. Is there any way you couldn't email them out either, could you? Because I know you said it was the
It's because there's a video in with it, that's why.
It would be really good to see.
What can I do? There's nothing, is there? Share content. There, that one.
Yeah.
And then desktop. Now that's changing. So we can see the first slide again now.
Can you see the second slide?
Yeah, now we can see the second slide.
Oh, lovely. Third slide.
Thank you.
So should I just do it like that rather than go? Okay. I'll do it that way then rather than do a slideshow. Okay. Sorry, Ashley.
No, thanks
very much.
Right, so I'll just pick off from where I left. So it also offers a child a sense of normalisation in unfamiliar and clinical environments. Through play, we're able to build a relationship and trust with the patient as they may express any worries or fears they have, and we can help support the child with their anxieties and feelings and liaise with the play specialist for further support. We're often asked to encourage children to play to help the wider multidisciplinary teams monitor their progress in hospital. So this could be making notes on our Meditech system of our play sessions for them to go into and have a sense of the child and their abilities. On my ward on the cardiac, we liaise a lot with our physiotherapists as mobilisation is one of our key targets to focus on the recovery of a child. So they'll have drains in and the child can't leave until those drains have came out. So the more they mobilise, the more the drains will drain and then they come out. And that is it from me.
Okay.
So our aim is to bring fun into the hospital, support the whole family and speed up recovery.
Thanks, Ashley. Okay, so that's Ashley's role as the play leader, and then from there, whoever's keen and interested can go on to do the Health Play Specialist Foundation degree. So I'm going to introduce you to Rachel now, who's going to give a little bit of information about this.
So hi, I'm Rachel, and currently at the moment there's two routes for the career development. For the one option is being a Health Play Specialist course, and the second option is the apprenticeship, and that I'm currently doing that at the moment, and that's a two-year course, and it's a foundation degree. I have 1 day at placement and 1 day at university, and obviously it's Leeds, and at the moment with COVID times it's online. I have to say I'm really experienced in the world of the Health Play Specialist and what they do. It's absolutely amazing, and I'm enjoying the course, and it's given me a good outline of what we do and the different areas and specialities around the trust. So I work on a day case ward, and when I do my placement day, I've been on cardiac, seeing the cardiac play specialists on there, which has been really great. I'm actually on medical daycare now for a block, and then so forth. So it's been really good seeing the different areas. Yeah, that's it.
Okay, so Rachel is actually my student, so I'm her mentor for this apprenticeship course, and so she does have different blocks on different areas to gain that experience, and it's also been really good for me to actually, you know, help Rachel to apply the theorist knowledge of child development into the role of the health play specialist and recognise that within her working days. So the foundation degree is required in health play specialist to become a play specialist, and we are registered with the Health Play Specialist Education Trust. We have an annual registration which we are required to complete, and if you haven't got that registration or you practice, then unfortunately you're not able to practice as a health play specialist. So our role is to facilitate play interventions for children and young people in the playroom or at the bedside, to encourage and provide developmental play interventions to aid the patient's recovery, manage a caseloads of patients referred to the play services, and we have a referral meeting, the Band 5s, every Friday morning, and we have a therapy desktop where all the referrals come in from throughout the trust from different consultants and departments, referring a patient, for example, a child who's struggling to have an MRI scan, who's not compliant for x-rays, who doesn't want a blood test, query of needle phobic, children who are struggling in school because of incidences that have happened in the hospital. They may be traumatised, they may have peer pressure, body images. There's lots of things that we can support our patients with. So these referrals come through every Friday, and we get several referrals every week, and as Band 5s we give them out to our 4s. Obviously the Band 3 would not take any referrals because they're not a qualified health play specialist. They facilitate and supervise the play, which I said earlier, they're a huge support towards while we're busy with referrals and doing preparation distraction. That Band 3 play leader is essential for us on the ward. So we help to prepare patients for medical treatments and procedures through therapeutic preparation sessions, and you'll hear a little bit more about this as we go on. We engage the patient in a distraction therapy during invasive procedures, and again that has to be appropriate to the patient's age and development. So you could have a 15-year-old with a developmental age of 4 or 5, so it's no good going in giving them something for a 15-year-old. We have to adapt that play or activity appropriate to their needs and skills and to their individuality, and work with that with regards to whatever procedure that we're supporting them with. We work alongside the MDT, as Ashley had said, as a play leader and the play specialist. We all work together, and we aid on judgment with the patients as well. You know, observations of our patients are really important, our documentation, which is important so that all members of the MDT can observe that. We complete an accurate timely documentation, which is absolutely important for every one of us. So you can just see a little bit there. We supervise structure facilitate play 0 to 18 years. We do preparation, distraction, diversional therapies. With regard to diversional therapies, I'm actually hypnosis trained pediatric, so I use a little bit of hypnosis. A lot of our staff are guided imagery trained, so we use guided imagery, we use tapping techniques, relaxation. We have lots of diversional therapies that we can implement for our patients. We're also on call, so we probably twice, sometimes 3 times a month we're on call holding the bleep, and you can be called throughout the trust for anything, for a child who's perhaps come in with a burns and needs the dressing done. You need to go and support them to A&E with a child with a shoulder manipulation that needs Entonox, because a couple of us are Entonox trained. I'm one of those. It's really helpful to be Entonox trained and go and help that child manipulate that arm, get it back in a sling and get them back home, rather than staying in overnight, having to wait for anaesthetics to have that treatment done. So there's lots of things that we can do. We attend clinical supervision as a band 5, and we also give clinical supervision to our band 4s and our band 3s. We work with our shared care trusts. So for myself, I work in oncology. For me, I share care trusts with Clatterbridge for children who are receiving radiotherapy treatment, with Preston for children who are having PET scans, and for Manchester for our children that are needing bone marrow transplants. So it's important that our information that we receive and we transfer is accurate for the patient to receive the best care that they can get. So our referrals I discussed earlier, we get psychology referrals. So we work alongside our psychologists very, very closely. Me in particular here in oncology. So I have supervision from our psychologist for oncology every fortnight, and we discuss the patients that I'm working with, patients who are struggling, patients who maybe the psychologist can't quite get a relationship with because she's not here on the ward all the time. It's easier for me to build rapport and trust and have a great relationship with that child to enable compliancy for procedures or whatever their issue is. Home visits for myself, I do home visits preparing children for radiotherapy and PET scans if they can't get into the trust. At the moment they're on hold, but for emergency ones we are still doing those emergency home visits. And again, documentation, huge part of working in the trust. It's important that other members of your team, not just the play team, but the MDT can see you've worked with that patient today. How did it go? Did it go well? No, it didn't. It was negative. What can we do to make that a positive experience for that child? That documentation is valuable for all of that. Teaching, as I'm teaching to you today, which wasn't a very good start, and I do apologise once again. We do lots of teaching and presentations to medical students. I teach on the radiotherapy course at Liverpool University. I do that once a year, just purely about radiotherapy and how I prepare patients for that. We have medical students, junior doctors, students like yourselves, and we also have mentoring students as well. So our roles quite versatile. We do lots of things, but within there is also the play, and that is what our role is about, how we do all our things through play, how we provide those activities for their children, recognising their development, recognising their regression in development, their withdrawal from being hospitalised. And it's important that as play staff, not just the play specialists, but the play leaders also have to be able to recognise those regressive states. So what is distraction therapy? Distraction therapy can be defined as a non-pharmacological intervention used to enable a child to reduce anxiety and pain by focusing on something other than the procedure. So that might be, I suppose you've heard, or maybe if you've got children yourself and they're maybe getting on your nerves, or they're driving you mad, or they've got a headache and they're moaning. You want to do something to distract them. And I know with my children, when they were growing up going to school, I used to use imagery. So we'd be walking to school and they'd be moaning, I don't want to go to school, Mum. I don't want to go and see that teacher today. I don't want to do my work. And I'd say, OK, where shall we go? And in our heads, we would go to Florida because that's where they always wanted to go. So as we were walking to school, I'd say, now, where's your suitcases? What are we going to pack this time? Which swimming costumes are you going to pack? We'd talk about what rides we were going on. And before we knew it, we were at the school gates and I was waving, bye, see you later. Off we go. They were in. That's distraction. Another form of distraction, if you remember, being maybe in the classroom when you were allowed to be in the classroom, or take yourself back to school. When you're in school, for me, I always remember staring. It was a teacher called Mr. Dyson. God help him if he could hear me talking now. And it used to bore the life out of me. And it was fractions. Don't know why I ever learned fractions. Hated maths, but I have to do it. So he was discussing fractions, and my eyes just totally went out the window in the classroom. And I saw a woman walking her dog. I could still hear him whittering on about fractions, quarters, thirds, a lot. But I was focused on that woman walking the dog in the playground and on the field. That's distraction. I was distracted by that. And we use that same type of therapy to distract our children from procedures. So today I've been in the treatment room distracting a child for an invasive procedure and for a non-invasive procedure. So we've done an NG tube and we've done a cannulation. So for those children, we've used distraction in different forms. So we have lots of activities and we have distraction tools, and they could be like bubbles, Play-Doh, find it, see it things, distraction books like Where's Wally, lots of squidgy things to hold on to, just to take their mind, or do counting exercises. Can you count back from 100? Are you really good at breathing fast? Are you good at breathing slow? What does mummy do? Can mummy talk in Welsh? Can mummy count in Welsh when you've got Welsh children? There's lots of ways that you can distract your children. There's lots of activities and distraction tools that we have that we can use, and that works to enable the patient to develop coping strategies for future treatments and procedures, allows the patient choice and control. So in our treatment rooms, particularly in oncology, we have a shelf, and every week we change those distraction tools on there, because for oncology patients, they're coming back quite frequently, sometimes weekly, fortnightly, monthly, and we don't want those same resources to be there. We want to change that. So every Monday we change those resources that are out there, and we use those distraction techniques. Believe it or not, one child today wanted to wear the biggest sunglasses ever. They had sunglasses on, they had a mask on. They don't have to wear a mask for children in here, they can come in without a mask, but this child wanted a mask on. They were having a cannula done, so they had headphones on, listening to the music, the biggest sunglasses we could find, and their mask. Do you know what? It worked, and that was good distraction for that patient. We got it done. They couldn't hear anything, they couldn't see anything, and we'd use the Amatop cream before, and Buzzy, which is a bit like a TENS machine, to aid with that pain relief as well. Child was absolutely brilliant. So then looking at that for the next visit, we've remembered what we used, how we used it, and we can use it again at the next time that the child comes in. And that also gives the patient choice and control. When all our children come into hospital, choice and control is taken away. Everybody wants a piece of them. Everybody wants to examine them. All the medical students and doctors want a piece of their history, and that's for the parents as well. And it's our role to give choice and control back, and that could be a finger prick. This morning I've done about 4 finger pricks with children this morning. It's like, which finger do you want to use? Let them choose. Which plaster do you want on? Do you want an NHS one, or do you want a special one out of Pip's Magic Box with all the pretty plasters in? It's giving that choice and control, and that sounds ever so small, but that's really important that we give that choice and control back to the patient. And the type of the distraction used depend on the age of the child and development. As we said earlier about age and development don't always go together. It's important that we're able to recognise that. And that's the importance of the training for our girls, for play leaders, for the health play specialists, the importance of learning that development, the theorist knowledge behind that. That's really important for the girls to be able to recognise when we have patients in who are regressed with their development. So therapeutic preparation, this is using appropriate language and tools, medical treatments and procedures they may require during the hospital experience. So it's to help a patient understand their illness and treatment. So obviously for me in oncology, and some of you don't know what oncology is, that's children with cancer. So we have an awful lot of children who attend this unit, and for them it can be really hard for them to keep coming back week after week after week. We only had a young child last week who just absolutely broke down and said, I can't do this anymore, and she was 12 years old, and the reason why when we sat and listened to her was the fact that she knew having her chemotherapy would make her sick for the next 4 days, and she'd been doing it for months and months, and suddenly she just said, I can't do it. So it was my role then to sit with her, look at how far she'd come, and that, yeah, it isn't nice, but it's actually helping to make her better. So once you've sat and chatted and found different coping strategies for her to work on, that patient was then able to carry on and have her treatment last week. And that's for us to be there, to be part of their journey with that patient, but also to correct any misconceptions or fantasies the patient may have. And I think we're all a little bit scared. It's fear of the unknown, what's going to happen. We want to give the patient an opportunity to express their feelings, anxiety or fear. And very often you find it's the teenagers that come in and they try to hide. They want to be big and strong, particularly the boys. And it's quite heartbreaking to observe that when you think, oh, come on, mate, just let it go. Let us know what exactly it is that's wrong with you. And sometimes they're a bit embarrassed to be scared of having a needle. And for our patients, particularly oncology ones that come in regularly, I actually don't blame them. It is horrific, some of the procedures that they have to go through, and that's our role to support them with that and explain that, do you know what, it's okay to feel like that. It's all right to feel anxious and upset, let us help you. And if need be, we'll do a referral to psychology to get that support for them. But it's always really important to give them that opportunity to express those feelings. Increase the patient's ability to cope with treatment. I said about that girl last week who was refusing treatment. Talk about it. Listen to them. What can we do to help? It's important you have this treatment, otherwise you're not going to get better, you're going to get poorly. What can we do to help you? That's the role that we have in speaking to that child. And our aim is to reduce the short or long-term psychological effects of hospital admission. And believe you me, I've seen that over the years, the effect that it does have on the children, and that it's important to address it at the time and deal with it, not to brush it under the carpet. And to enable informed consent. We want the children to consent to the procedure. We don't want to force them. We don't want to hold them. And at the moment, we've just, I think Alder Hay have just written a new clinical hold policy, which I think is in the process of going out. Informed consent to hold is really, really important for us, particularly us doing our preparation distraction. We are called into the treatment room to support those patients. And you do learn all that through your training on the Apprenticeship Course or the Health Play Specialist course, and also within your training, like for Rachel, who comes one day a week on her different wards. That's what she's learning. What techniques, what are the play specialists doing? How can I learn that? How can I offer that support to the patient? And it's not nice to be in a room for a child who's having a cannula and 3 people having to hold them. It's totally wrong. And it's our job to say, okay, give me 10 minutes, let me have a chat with them. What can we do? What can we offer? What pain relief have we got? What distraction have we got? Post-procedurally, how we can support them? What was their previous hospital experience like? That's all the information that we need to gather, but we have to gather that in a split second. We don't have a long time to do it. And that's how important it is for us to be able to recognise those issues that come up. And you know what? I've just put a slide up there, will it hurt? Unfortunately, that is all our patients are thinking, will it hurt? They're not interested in anything else. They want to know, whatever you're going to do to me, is that going to hurt me? And it's our role to reassure that, but also to be honest. It's really important that we're honest with our patients. If it is going to hurt, tell them it's going to hurt. I've told 3 children this morning, yeah, your finger prick will hurt, but just for a little bit and then it'll stop. We'll put a plaster on, we'll give you magic cream if that's what you really want. Magic cream doesn't really work on finger pricks, but if that's a placebo and it works that child psychologically, then we do that and we support them with it. What else can we offer? Is it going to hurt? How much is it going to hurt? How long does it hurt for? These are all the questions that the children will ask. And it's important that we recognise and, again, listen to what they are. The reassurance, the earlier we get a referral, which I discussed earlier, so we have our meetings on a Friday, get our referrals and we give them out band 5s to our band 4s. The earlier the referral we get as a health play specialist, the essential that is to alleviate fear and anxiety. The more time I've got to work with a patient, the better. Very often it doesn't work like that. And for those that have come this morning to me, it's like, Pip, such a body's having a finger prick, they're not complying, screaming, can you go in and help? Okay, I can go in and help, but why didn't you call me before? Why'd you wait until they're screaming before you call me? Let me get in before. The more time we have to work with the children, the adults, the young adults, the more chance we've got to alleviate that anxiety and fear. Communication across different departments or shared care trusts. Again, for me going to Clatterbridge, it's important the information I get is the correct information for me to be able to prepare my patient for the procedure that they're going for. And so I'll share care with Manchester, Clatterbridge and Preston for PET scans. And it's important they know who I am, what my role is, and that I'm going to get the child that they have to work with prepared for that procedure, whether it's radiotherapy, PET scan or bone marrow transplant. That's our role. And as Ashley talked about working in cardiac, there's so many different wards and departments in this trust that all require the value and input of a health play specialist or play leader. And it's important that we communicate across different departments to get that shared care information back to our patients. So familiarising the patient with strange apparatus and departments. So for me, I'll go to Clatterbridge with my patient. I'll do the planning and the prep beforehand, so they know exactly what's going to happen, who they're going to meet, who's going to be there, why are we doing this? And very often that's a question that's missed. Why do we have to do it? Why do I have to have chemotherapy? What's the chemotherapy going to do? Why does my hair fall out? And it's actually when you address those points, your hair doesn't fall out because you're ill, which is unfortunately what a lot of the children think. Your hair falls out because of the chemotherapy, and that tells us that the chemotherapy is working if your hair starts falling out. So you can have like a positive slant on something that's quite negative for that patient. And again, that's important for us to talk to the children, familiarise them with different departments, go into Clatterbridge, going along with them, showing them props and things. So our patients have central lines or portacats inserted, and for our children, we can't really show the next person in the next bed. Sometimes we do if they're happy to show them. So we have dolls that are medically prepped for that. So we have lots of dolls with central lines in, we have dolls with portacats in. I do lots of surgery on these lovely dolls, get my drill and my tools out, and I put NG tubes in the nose. They have cannulas, they have all sorts of things in, and that really helps with our children. A little role play in particular for the young children is amazing. And if you're doing it on a doll and you send them home with a little syringe to give Dolly a drink, or do the dolly's dressing, that really helps. And so familiarising the patient with strange apparatus and departments really, really is important. If they go into X-ray, for me working with children who don't want MRI scans, we've got a mock scanner downstairs in our MRI department. So we take the children, we take their cuddly toy or the doll, and we let the doll have a scan. When we go in, we inform the staff first, this child's struggling to comply, help us, can we come and visit, can we look at the department, can we look at the machinery. That's really important to familiarise the child with that. And also through verbal explanation, using the preparation dolls, hospital play, photograph, preparation books, they're really important. But for me, when I'm doing stuff, it has to be the real McCoy. Even if it's with hospital play, it has to be the real things. The preparation dolls has to have the real central line or portacat or cannula. It's no good putting a pen lid, sticking it on with a plaster. It's not right, because that's not what's going to happen. They need to have the real medical stuff on them. So procedural communication, whenever a child is coming in for distraction or preparation, it's important the child knows what they're having done, and that can be from the parents as well. So for me, when I'm working with a child, I always find out from the parent, how much information does this child know? Does this child know they're having a finger prick? Does this child know they're having a scan? Does this child know they're having radiotherapy? And that is a big, big question for our parents, for them to discuss and have that conversation with the children. They do need to let them know a certain amount of information. The younger they are, they don't need too much, but the older they get, their knowledge and information and processing is far greater than that of a younger child. So it's important they have that information to them. Another reason being is, for me, going to Clatterbridge, when you get to Clatterbridge, it says Centre for Cancer. Clatterbridge Centre for Cancer or some oncology, something like that. So if you've got a 12, 13-year-old, they're going to get there and read that straight away. If they already don't know why I'm coming here, you've already got barriers up, boundaries are there, and they're not going to comply. So for me, when I meet with the parents, I find out how much information the child knows, how can I help them, how can I support them, who's going to be there, how long will it take, what the patient needs to do, and what's my role within that. And my role is to be an advocate for the child and make sure that they come to no harm and that people are listening to them. And if the child says, no, I don't like that, I don't want to do it that way, but I can do it this way, if that's possible, then we do it. If not, then we say to the child, we can't do it like that, but we could try it like this, if that's all right. And again, it's going back to that choice and control. You're giving choice and control back to that patient. And it's important that we recognise that. So the patient's perception, how a child perceives their hospital experience and long-term effects of negative situations. And this, obviously we're talking about paediatrics here, but this could be from yourselves. How many of you like going to hospital? How many of you like waiting in the waiting rooms when you wait for hours and hours and you think, I'm sure they forgot about me. I've done it, did it last week. I'm sure they forgot about me. And you sit there and then you go and ask and they say, no, you're next in the queue. And you think, oh, here we go again. Our children feel exactly the same about that, their waiting experience, how they perceive it and the long-term effects of those negative situations. And that can be from just sitting in a clinic room waiting. It could be from someone not listening to them. It could be from the child saying, no, I don't want it, and someone doing a clinical hold and putting that cannula in. Absolutely wrong, and that's what our role is, to recognise the effects of those negative situations and again document, as we said earlier, making it known to everybody else who reads that this child doesn't like to sit on the mum's knee when they have a cannula in, this child likes to sit on the bed and have a little bit of control, or this child does like to sit on mum's knee, put their arm around mum's back as if they're having a big hug, You know, it's important that we put those important information down so that everyone can see. And again, when we're working with children, we need to identify the problem, if there is a problem. Sometimes there isn't a problem and we just sail away and it's beautiful. I've had lots of children today who've come in for line dressings, different procedures, and we've had no hiccups. A couple of those who were struggling with finger pricks, but we've got them done and we've worked with them. We've looked at ways that we can support them next time. So if there is a problem, identify what the problem is. And sometimes that problem can just be something as simple as someone saying a wrong word. You know, the medical terminology isn't the best. A lot of our patients do get to know medical information, can talk and can tell anybody about what their leukemia is, how long it lasts for. You know, a lot of the children learn that. But sometimes they're unsure what it is. And if someone says the wrong word, then you've lost that situation and you won't get compliancy. So it's important to us to identify what the problem is. And sometimes that problem can be the parent as well. If mum and dad are upset, or the carer or family friend who's with them, if they're upset, then your patient's going to get upset. So it's identify what your problem is. Next time, maybe dad come in instead of mum. You know, it's important that we look at those situations. How can we resolve that? Identify the aim. What's our aim? Our aim is to gain compliancy for that child to have the treatment. Identify the method of approach. How are we going to do that? How are we going to get that child to comply to that procedure? What can we do? Does that procedure need to be done today? And that's the biggest question that I ask for all our patients coming in. Does it have to be done today? Can I work with them tomorrow? Can they come in the next day? And if we've got time to work with them, then we'll work with that patient. If unfortunately we don't have time to work with them, then we can't. And it's a case of, do you know what? We need to do it now. But our ultimate outcome is to empower the patient to cope with the hospital experience. You know, lots of children have to come back again and again to this hospital. And it's our role to empower that patient to cope with the hospital experience, whether that's through therapeutic distraction or preparation, or as a role of the play leader, providing activities to relieve boredom, to make them enjoy their stay, to make it fun. You know, it's bridging that gap between hospital and home. That's what we have to do. We have to make it a nice place for them to come. Yeah, the treatment can be rubbish. Yeah, the injections aren't nice. But you know what? It's nice going to see Ashley because she gives me nice things to do. Pippa always helps me with her procedures. Rachel helps me when I'm going to theatre. It's important that children know who the people are who are on their side, who are advocates for them, and to empower those patients to cope with that hospital experience. So play is a powerful tool that gives the patient a voice. And I know we've lost quite a lot of time today, and I do apologise for that, because there was a lovely little video that I wanted to show you, and I don't know how much time I do have left. But one of the things that I wanted you to see is that how through your training that you learn that preparation is so important for our patients. So this next slide that's coming up with regards to preparation and distraction, you see a beautiful little girl there. You can see her hair hanging out the mask. This child needed radiotherapy to her brain, and so this mould was made over her face. This child is awake. This child is 4 years old. So it's our job as a play specialist to get this child to comply, to have that done. That looks quite scary there, and it takes about 15 minutes to get that procedure done. It's my job to prepare that child to try the medium, which is plaster of Paris. There's cling film underneath. There's Vaseline on the head to stop the plaster sticking. They put little markings on the side of the head with pencil. And when someone draws on plaster of Paris on the side of your head, your ears are so close, it just vibrates. I've had this done. I wanted to try and see what it felt like. It's quite invasive, but you know what? It does not hurt at all. Nothing hurts about that. It's just our reassurance, ego strengthening, building the trust in that child to be able to comply, to have that mask made so they can go on and have radiotherapy treatment. And you can see in the side there, the little marks on the side where the member of staff's putting the pencil marks on to where the mould's going to fit. That's important that child stays still for that. And for a 4-year-old, that's really, really good to be able to do. I know in London, 5 years and under automatically have general anaesthetics. Now, for radiotherapy treatment to the brain or spine, they require 30 fractions of photon radiotherapy. Sometimes there's protons, which I'm sure you've heard in the news now. We have photons and protons. This little girl was photon treatment, and she needed 30 fractions, which is Monday to Friday. And your radiotherapy, each fraction for a brain or spine, lasts roughly about 6 minutes, if that. So they could go to Clatterbridge, put the mould on, have the treatment, 6 minutes, they're on the way home. It's that fast. It's this planning, making the mould that takes the time to do. And it's our role to be able to get that child to lie still and comply to that procedure as well. And that can be really, really difficult. But we've learned over the years, and we're really, really good at Alderhame. We get 4-year-olds. I think the youngest we had was a 3.5-year-old, and she wouldn't leave go of her dummy. And as I said earlier, what's your obstruction, what's your aim, what's your outcome? For her, you know, what obstructs compliancy? For her, it was her dummy. She wanted to suck a dummy. Well, having radiotherapy, she's not allowed to suck a dummy. But what the staff did, they made a bigger hole, because her mask was, if we look at this next slide, her mask was one like this one. So we used to always use this just for palliative radiotherapy. Now it's used for proton and some photons now. So this little girl was having photon treatment. So they cut a hole just in the mouth bit there, so we could shove the dummy in, give her a little suck, and we'd count to 10, and then we'd all run out the room. She'd have her treatment, and then we'd run back in. We'd say, sucky dodie now, and she'd put a dodie back in. And again, it's finding out what works for that child and how we managed to get that child who was fastened down by that mask on the bed, how we got her to comply to that treatment by using the dummy, which was her soother, her comfort, which was her reassurance for having that treatment. And she did it. She did 30 fractions of radiotherapy, sucking a dummy every time the staff ran back in. You can suck your dodie now, and they ran out. That's what we have to do. We have to find a link with that patient to offer them reassurance and think, do you know what, we can do this. But again, it's all done through play. So the playing with her, we were doing counting games, we were doing nursery rhymes while she sucked a dummy, and she had to hold it by her side and stay nice and still while the machine was moving around her. And again, here's another little boy. So very often we'll paint the masks and the moles for them if we have time. And they always like that. We cut the eyes out for this little boy. But again, you can see his mouth's not cut out on that. So we cut hers out. And again, like I said earlier, can it be done? Can we change that? Can we put a hole in? If not, absolutely, we'll work and find a different way. But if it can, let's do it, because we're going to get better positive patient experience. And more importantly, the patient is going to comply to that treatment, which is very important for that child. So there's another little one, and this was actually on a Halloween day a couple of years ago, 2 or 3 years ago, whatever day. This was a Thursday, so Halloween obviously fell on a Thursday a few years ago, and she come dressed up. So this is a little girl having her radiotherapy treatment. So the machine that gives the treatment is called a linear accelerator, which you'll see on the next slide, and the child is fastened down. You can see that bed, it's actually rock hard. So if I knock on this, that's how hard that bed is. And we do a little cushion, a vac bag to go under the head. And again, look at her thumbs up on Halloween, Scream Queen, having her radiotherapy. Absolute superstar. And it's our role to get that child to be able to lie still for that period of time, chin up so it fits into that mask, arms by your side, and just bearing in mind that there's nobody in that room whatsoever, just that child. There's no staff, there's no parents. And I have to be reassured that that child is going to comply to that. I don't want that child to try and start rolling off the bed or get up. I want that child to be as still as possible, because I want that child to have her treatment to be able to help and give her better quality of life. That's what's really important. So to do that, we use play, we use lots of tools. For this little girl, she loved Cinderella, being a princess, Alice in Wonderland. So we used to pretend that she was Alice in Wonderland, and she'd gone down the hole and she'd shrunk really, really small. So the bed didn't seem that big to her, because she was very small, because she was Alice. And then as soon as she lay down, the bed was huge, because she was Alice in Wonderland, and she thought it was amazing. And she was able to comply to all her treatment and did absolutely well. So that's the linear accelerator. So the bed that you just saw, we just took out of the shot, and that's the machine that gives the radiotherapy that spins round to all our children and goes all the way around. It treats the spine underneath, and then it goes back to the top over the head. It comes very, very close, within a couple of inches of touching your face, but it never touches you. You can't see radiotherapy, you can't feel it, and you can't hear it. So when I'm doing my preparation, it's important that I inform the children of that, and the young adults. And sometimes the young adults get really, really scared, because they can get claustrophobic, and that's where my skill and knowledge comes in. With hypnosis and imagery, we can help support them to use techniques to support them to get through this radiotherapy. Occasionally we do have children that unfortunately can't comply to this procedure, and as you've seen in those masks, they look invasive, they look quite, traumatic, barbaric, as some people would say. that actually not, it doesn't hurt having those made. It just is the fastening down to the bed. There's 5 buttons that fasten that mask down. And again, going back to the very opening slide, it's loss of trust and control is taken away from the children, and that's what happens with this. And again, it's our role to give that back, to reassure that child that, you know, we're watching you on the TV screen, you're not going to fall, you're absolutely safe. Use your techniques, use your breathing exercises, your relaxation that we've taught you. Use all those skills and just focus. It's literally for a few minutes and it'll be over. And we find that once they've done a few days, the children get used to that, and then they just run in and they drive the staff mad, you know. But unfortunately, there are some that can't actually comply to that. They find having that mould too traumatic. They can't lie still. You know, children who can't comply to MRI scans or CT scans, then I would say, do you know what, let's look at having a GA for this child. If they can comply to an MRI scan, a CT, then I'm quite happy to put the work in and work with them. And it is hard to get them to comply to that, but it works really, really well. So we are the best in the country of avoiding GAs for radiotherapy, which is rather amazing. So I'm just going to skip this next slide because it is a video and I don't know how much time I've got left. So I just want to shoot through these, and if I've got time, I'll just click on that video a little bit. So clinical effectiveness of our role is we're non-pharmacological. Apart from a couple of us who are Entonox trained, and that's when we get called on course like A&E, manipulate a shoulder. There's not many of us that are that. So apart from that, we are non-pharmacological intervention. We provide personal self-control. We encourage that child, compliancy, play, aids recovery. We stop bed blocking. So if I'm doing Entonox with a child, like, you know, last week in A&E, and that child has their arm put in plaster, sling on, off they go, they're home. We stop that child blocking a bed for someone who may come in an emergency, but also you give that child a good positive experience, and they're going home, they can go back to school again the next day. And play builds trust, it forms relationships, and you know, the three of us agree that the relationship you build up with your children is just incredible. Only yesterday I was cleaning the paint cupboard out. We still have to do those jobs, paint cupboard, glue brushes, all the lot. We still have to store our resources and, you know, follow the toy cleaning policy that's implemented within the trust. And I was cleaning out mine yesterday, and this young girl come tapping me on the shoulder and she said, I bet you don't remember me. And she's now 14 and she was 2 when I used to look after her when she was little, you know. And it's lovely to see that child, first of all, being so well, but the fact that she remembered me, and she said I hadn't changed. Obviously I had. I'm very old and wrinkly now, so she did notice that I changed, but it was so lovely that she remembered me, and that relationship was still there from all those years ago. You know, it's important that we ego strengthen our children, we enhance the health and the well-being of the patient, but not just the patient, the family, the siblings. Was heavily involved with the siblings when they come onto the ward. Unfortunately, at the moment, due to COVID, there's no siblings allowed. There's only one parent, and that's heartbreaking. It's heartbreaking for me as a parent and a mum to think, gosh, how would I cope with that if I was in their shoes? You know, I'd find that really, really difficult to deal with. But it's important that we recognise that, and so we send like little postcards home to siblings from the patients who are in. We do FaceTime with them when they're having like music therapy or the art therapists, which we have on the ward. We'll always do a FaceTime video so they can see them, they can see what's happening to them when they're in hospital, and they can also see what's happening to their siblings at home. So it's really important, the health and the well-being of the patient and the family as a whole. And as I said earlier, play bridges that gap between hospital and home. Sometimes they don't want to come if they have to come regularly, and it's our job to make it a nice place, a place that they want to come, you know, and learn from, have fun, as well as having their treatment to help make them better. So in reflection, what we have to do continually all the time is think of the patient's hospital experience. How can we make it more positive? What can we do as health play specialists to make that child want to come back again for that treatment? How can we make it positive? How can we empower the child? What can we do to give them that power and support that they need to get through this treatment or procedures? What barriers obstruct progress, as we talked about early? That little one having the radiotherapy, a dummy, she wanted to suck a dummy. That was obstructing our progress. We sorted it. You know, for another one, a parent could be the, you know, obstructing that progress. Chat to them, talk about it, talk about words. Don't say this, let's say it like that. What can we use? Look at what's obstructing your progress and you can fix it. and positive patient experience, and most importantly, the child's views. And what I'll always say, with regard to communication, listening is one of the biggest aids in communication, and that doesn't mean as in hearing vocally. That means taking that time to listen to that child, whether it be verbal, non-verbal, whether they're writing to you on a piece of paper, whether they're writing on a postcard or on the internet, whatever. It's important for us to listen to the child's views and see if we can change and alter that child's perception of hospital. How can we make it better? That's really important. So in conclusion, good preparation builds trust. It gives control back and it aids compliancy. Every patient is an individual with different needs, and that's going back to the very beginning where we talked about development and age and how every child has different needs. We have lots of children on the spectrum here in the trust, and even every one of them, they might be, on the same spectrum plan, but they'll be totally different. For me, on this ward, we can have 5 patients, say girls, all diagnosed with ALL, which is acute lymphoblastic leukemia, on the same day, same age, sex, same treatment protocol. They'll all respond differently. And the reason is because they're individual, just like we are, and we have to recognise what their individual needs are and offer them the right support. And hopefully that will result in a positive patient experience. So, Cathy, I'm at the end of my slides now. Have I got a minute just to show a little bit of this video or not?
It's if you can share, that's fine.
Are people still there, or do you want me to finish?
Can we have anyone who's, I suppose, if we can just have a show of hands for if people can stick around to see the video? You just raise your hand on the hand raising tool.
I don't want to bore them too much, you see, and I want to see if they've got any questions.
No, all the hands are coming up. We have got questions, though. So
okay, we do questions first, then, in case we don't get time.
Okay, that's
fine. Go on, let's go.
Okay, so I've been keeping an eye on questions, and lots of them around routes in and requirements. So you told us about the apprenticeship route, and we heard from Rachel that she's doing the foundation degree.
Yeah.
I think the questions were really about, well, is the apprenticeship route, is that the only route into your service and your job role, or are there other routes?
Okay, so the routes are that you could come in as a play leader, as Ashley has done. So you just need your MVQ level 3 or nursery nursing, and we do look for like maths and English grade C and above in that for that band 3 play leader. So that's that role. And then there's if you wanted then, so once you're in the trust, then you could get offered an apprenticeship course, or you could get offered where the NHS pay for you. They paid for mine hundreds of years ago. It was about probably 25 years ago. They paid for me to do my training, and that's really good, so you don't have to pay yourself. So if you get your foot in the door and get in as a play leader, then the possibility is that the trust will pay for you to do that training, either as an apprenticeship like Rachel did, or there's the health play specialist course, which is at Leeds the same, but it is 9,000 a year, isn't it? So it is, it's self-funded. But again, if you're in-house in NHS, they could possibly pay for you, but they are looking at apprenticeship routes. And then once you're in, you've got that, then you can move up to your band 5 and your band 6 once you're in the trust. Does that answer the question?
Yes, I think so. One of the things that someone had put in was, with regard to the apprenticeship, can you do the apprenticeship if you've already got a degree?
Yes.
Yes. Okay. And I thought so because actually when I was looking on your staff pages, one of our graduates, I think, is in your team, although I believe she's on maternity leave at the moment, Anna Kelly.
Oh, yes, that's right. Yeah, she's just got on mat leave.
Yeah, so Anna did early childhood studies here.
She did.
Yeah. Yes. And then she's obvious, I think, am I right in saying that I'm guessing from what you said, Philippa, that probably Anna joined as a play leader? And
No, she didn't actually. I think she was self-funded and did the training herself, and then came into us as a play specialist. Yes.
Okay, fine. Okay, so that I think that clears that up. But if there are other questions, I know Katie's put a question in the chat there to say, are there apprenticeships for play leaders? But I think you've answered that, because you've kind of said that you can get in and go that way. One of the things that I wondered about was just how often those apprenticeship opportunities come up. Are you a big team? Are you a small team?
There's about 18 of us at the moment, and we've got 4 band 3s, So, we've got one, Rachel, at the moment, and I think they're looking at another 2 for next year. So I think it's going to be on average 2 a year, I think they're looking at.
Yeah.
Which is really, really good because, as I said earlier, I am old and I'm not just the only one. There's quite a few of us of that age. And, I'm looking to retire in the next couple of years. So we need people, we need not just young people, we need mature people who are interested in this role. And it's such an amazing role and you get so much fun. I wouldn't have done it for 31 years if I didn't enjoy it. What you get and what you give is just amazing. So absolutely, yeah, couple of years. It has only just started. Last year was the first time we've took apprenticeship for this, but it's a brand new course at Leeds City College. Yeah.
Yeah. Okay. And Hannah's just said there, where are the apprenticeships advertised? Is it on the NHS jobs?
It is. Yeah.
Yeah. Okay. And it's a 2-year apprenticeship, isn't it? I know Chloe's asked that, but I think you said it was 2 years.
Yeah, it's 2 years, and Mondays is the college day. So you do have to go to Leeds. At the moment, they're very fortunate, so it's online. I think they go once every, how often do you go?
It's been in blocks at the moment due to COVID. So I think I've been in, it'll be twice at the moment. We are hoping to get in one more time before we've completed the first year. Obviously, when COVID's over, when that might be, it will be once a week going to Leeds. Yeah.
Brilliant. And with regard to just again thinking about those opportunities, Philippa, what kind of experience and skills do you think might be looked for? Because I'm thinking that if students are considering this now, then it might be a good idea for them to try and get the right kind of experience and skills while they're at university, so they can look out for opportunities.
Yeah, I think child development's a big one. I know we've sat in on interviews a couple of weeks ago because we're trying to get a bank supply of play leaders because we just don't have enough staff at the moment. So the trust have agreed to pay for bank staff. So if any of you, do have an MVQ level 3 or nursery nursing, keep looking at the NHS because we are looking for bank staff to cover. So you can get in. It's important that you've got your child development, that the knowledge is there, absolutely needed. If you just look at the presentation today, the knowledge, you have to have that knowledge to be able to work with the children to get those things, remembering your theories all the time. But also I think is your documentation. So you do have to be pretty good at writing. I found documentation difficult purely for the fact that there was so much of it. Like for me on this ward today, I've seen 18 patients today that I've actually worked closely with. So I have to write notes for 18 patients today. And it's finding that time. So it's a bit of time management, good documentation. But you do get taught all that as well. So don't panic about that. But I think knowing your development, knowing what play is all about, how you can use play and that tool. There's lots of research out there about play and how we use it and stuff. And also, at the moment, it's not possible. But, contact the hospital, come in as a volunteer. I have volunteers coming to me every Wednesday and they've just accepted her to come back now onto the ward. And she loves it. She absolutely loves it. And she's thinking of, moving further and looking at the apprenticeship. And so there are ways, ask, can you shadow? There's lots of ways that you can get in. But I think for the students at the moment, documentation, your child development, look at play, what play is, how can you use it? Because I know for Rachel, this first year the course has been focusing on like theories, development, making play programs, how you plan a play program for a patient coming in, how can you improve that? So there's that type of stuff really.
Yeah, brilliant, thank you. One of the things that we've got a question about, and it was in my mind, if we have students who are doing a relevant degree but they haven't actually got the NVQ, is that viewed as an equivalent, or do they actually have to have that NVQ?
Is it the early years?
Yeah, so we've got various courses, like we've got children's, Chloe's put up she's doing children and young people's learning and development degree, and we've got a fair few sort of early childhood studies, we've got
we
children.
recognise the childhood study is definitely recognised. I can tell you that one. But if you want to drop them in an email to me, I can find out definitely for you. I'll contact HR. There is a criteria, obviously, that they have to fit with regard to that. And it does seem a little bit unfair, doesn't it, when they've done a degree and you think, well, I've done my degree, so I must have it. But actually, is the questions that come out at interview, you need that knowledge to be able to answer, if you get me. But don't let that put you off. If you send me an email with what the courses they're doing, and I'll confirm with HR whether they would be acceptable or not. Is that all right?
Yeah, that's wonderful, because I've just had a couple coming up there saying that they're doing early years primary teaching, and would they be eligible? So again, I guess it's probably HR need to look at it and make a decision on that.
Yeah, I know the primary teaching one's not recognised. Sorry.
Yeah.
Oh,
right.
That's cruel. I'm so sorry.
Yeah, no, it's information that we need to know.
Yeah.
Okay, that's wonderful. Thank you.
Is that all?
So I'm just looking to see if there was, a couple of people have asked if they have any questions, can they email you? I wasn't sure how you wanted to deal with
Yeah, I'm happy with that. Yeah, give them my email. It's okay. It's my work one. I'm okay with that.
That's wonderful. I'll share that then. I'll put it out with the slides. Oh, and will we be able to have a copy of your slides? I know you can.
Yeah, I know. If I can just remove the video, I'll do that tomorrow. I'll remove the video and I'll send that to you. Is that all right?
Yeah, that's perfect. So I think I've asked all of the questions. I noted down. Just if anyone's listening there and I haven't asked you a question, do you want to quickly type it in chat? And we'll see if anything comes up. I think we've asked everything. It sounds like a really fascinating role, and actually really so crucial, actually. Just having had children myself who've had to had treatments in hospital, it's really crucial to have someone to kind of to help it seem fun and to just reassure them, really, I think.
Yeah, it is. Yeah. I mean, there's a lot of learning to do once you are here, like the medical background side of it. That is quite difficult initially to take on board and learn. But, you know, once you're here, your time here, you get to learn all those, you know, procedures and treatments and what they mean. You know, for me, I'm trained in oncology, so I'm the oncology play specialist. Ashley works with the cardiac play specialist. So you do, once you're in that area, you gain that knowledge and skill off that area, but it is still transferable because prep and distraction is the same wherever you go, and that's the important thing. You know, when we're on call, we get that experience of working in other areas and departments, which is really, really good. You know, I'm not a fan of burns, I'll be honest, and that's through childhood incidents that happened, you know, but I still have to do it when I'm on call, and I go and I do it and I prepare myself, you know, and crack on, because that's my job. That's what you have to do. But you do learn you learn so much. And as a mum, when my children were young and I was here, if they complained of a leg ache or something, you know, every week they'd have about 5 brain tumours, they'd have ALL, they'd have something wrong with them, because I'd be thinking, oh my God, they've got that. And that's your knowledge that, you know, that you learn, that you pick up throughout the years. But it is a beautiful role. You know, the band 3, band 4, band 5, can't speak for the manager, she'll speak for herself. But our roles are, you know, they're just imperative to the patients and the families on the ward, and so enjoyable. Absolutely.
Yeah. Absolutely. I mean, it really sounds crucial. Thank you so much. There was
You're
a
welcome.
question there, which was about from Chloe, who was saying if we don't have the MBQ, what would the next steps be? But I'm assuming that students would have to look to get that and then apply. Is that right? That's what I thought.
Yeah.
Okay, that's wonderful. Thank you so much.
You're welcome. You're welcome.
So, do you want to play the video? Have a go at that if you can.
Play a little bit if they want to. It's so beautiful. And what it was is we were working with this is all about radiotherapy. So you can see this is a tiny little model here. It might not even work when I try and press play, but I'll have a go. And it's just about the different types of radiotherapy that children go through. But the good thing about it is that the children made this. We worked with an animation company. I wrote the narrative, and I spoke with the staff at Clatterbridge, and, you know, our voiceovers are in it, but the children made all the models and the masks. All the children that had radiotherapy I worked with, I got them all involved, and we created this, and we actually won an award for BMA for best information, and it's just so good. And it does last about 17 minutes, and there's no way I'm going to play that. I'll just play a little bit, and then I'll stop it if that's all right, if it'll play.
We can't hear any volume at the moment.
Can't you?
No, we can see it. We can see it. It looks wonderful, but we can't hear it.
What a shame. It's got a beautiful tune as well. Okay, so it's no good that you can't see it, but if I just scroll, I'll just show you how. So this is someone who's just had a mask made, and then she's going to go out with another little boy.
Yeah.
Who's going in for his mould making, and this is like what we show the children. I'll just show you this little clip because he's going to have his mask made. And you'll see the process of what's involved.
Yeah.
And this is how we prepare the children.
That's wonderful.
So she puts that in the hot water, and then she has to pull it down, give the beanbag to keep him comfortable, and then she pull the back of the mask down over his face and fasten it down. So this trough with the hot water, the children need to know that this is going to happen when they get there. So you can see how hot it's going to be.
Mm-hmm.
Shake the excess water off. And all those little bits, the sound of the clicks that you'll see in a minute, they're really important that we tell the patient this is what happens. It feels like a warm fan going over your face. You can see how frightening that is. That little one that wants to suck a dummy, you need to put a hole in so she's able to suck that little dummy.
Yeah.
They go in and out that CT scanner. They need to be nice and straight, no bent bananas on my bed. And it's just your terminology, what you use, how to get the children to be able to stay still. So I'll leave it there because it does go on too long. But it's just a really good example of, you know, using resources to help prepare children for treatments and how they can comply to it, you know, and the importance of that information that we get from the Shared Care Trust and that we get the correct information to then prepare our patients. But absolutely, anyone wants to email me, drop me emails, questions. Yeah. I'm glad we finally got there in the end. Thank you very much. And thank you for having us.
Oh, it's been so interesting. Thank you so much. And thank you for bearing with us and keeping on trying when we're having those problems.
I'd love to come and do face-to-face, though I can't be doing with this IT stuff. I'm a bit rubbish.
Yeah. Well, once we're back on campus, if you're willing to, we'll arrange a face-to-face and that would be great.
That would be nice because then I can bring all the props and the nice things so you can see it visually. It's a little bit better. Yeah. You know, I could do a bit of hypnosis imagery so they understand that then as well. So that'll be lovely. Yeah.
Yeah, that's wonderful.
Oh, thank you very much. Thank you, everybody, for listening. Appreciate it.
Thank you.
Thank you. Bye.
Thanks very much. There's lots of thank yous coming in here from everyone. So thank you.
Thanks, Cathy. I'm going to have to fly.
Thanks very much, Debbie, and thank you so much for helping sort that all out at the beginning.
Oh, no problem at all. No, same thing happened to me back in the summer when I was running a webinar with ICE, so we had to put it all on Teams. So, yeah. I've got a meeting with ITV now, so I've got to fly.
Wow. Yeah, enjoy that. Thanks very much, Debbie.
Oh, no, thanks so much. Speak soon.
Thanks.
Bye. Oh, I've got notes.